talking to you today about a quite an exciting development in an relatively unexciting area. The patellofemoral joint tends to be ignored a little bit and has had very little attention in terms of tech, support, instrumentation over the years. It's almost the forgotten third space. So I'm just going to introduce you to a relatively new device that's designed to measure intraoperatively the pressures of the patellofemoral joint before, during, and after your knee replacements. So, as we know, we're all chasing the same problem. With total knees, we've got around a 20% dissatisfaction rate is commonly reported. I think many of us with high volume surgery believe it may be about 10%, but all the studies show somewhere between 5 and 30%. And this rather busy slide, but effectively they're saying the same thing. About 50% of these dissatisfied patients report anterior knee pain. And our fairly rudimentary attempts at resurfacing the patella or leaving it alone give great variation. And this is for measured resection, for mechanically aligned knees, and lately with the interest in the never-ending variety of so-called kinematic alignment, we're seeing increased pressures a lot of the time on the patellofemoral joint as people are adjusting the femoral and the tibial components. Over-resection, under-resection, or asymmetric resection in this study is reported in about 10% of patients. I'm sure it's much higher than that. And the incidence of anterior knee pain following total knee arthroplasty is disturbingly high. Now, the problem we have is with overstuffing predominantly, but also an imbalance of the patella. And if we overstuff the patella, we lead to problems with tracking and pain, with heightened tension along the well-innervated retinaculum. And only slight changes in a cadaveric study, 2 millimeter difference in the patella thickness had a statistically higher, I think this will point at this screen, statistically higher increase in pressure. In a cadaver study where we look at quadrants of the patella, just 1 millimeter makes a significant difference. So essentially what the device does is we open the knee for a total knee, and I also use it for the patellofemoral replacements. We take a conservative resection of the patella, so 7 or 8 millimeter resection of the patella, and then we apply this pressure sensor with a matched shim for the same thickness onto the sensor. We then cycle the knee through full extension to beyond 90 degrees, taking usually 4 readings, as 3 shown here. And we get 4 quadrants. There are 4 different sensors. And what it usually shows is high pressures in the lateral and superior sensors, as you see here. We then go on and do the femoral and the tibial components, and then repeat the measurement. And virtually always we see from the native knee on the left here to the trial implants a significant increase in lateral and often superior, but virtually always lateral pressures, which fits with patients' description of lateral and the most common distribution of lateral wear. This then allows us to fine-tune the cuts, both in thickness, but also, as James will show you in a minute, in terms of the angle of the cuts, in order to try to aim back to the native knee, or if the lateral pressures are very high, potentially to reduce those pressures. Now, the patellofemoral joint forces, there's a lot of factors that affect the pressures going through it. We're all taught, or most of us have been taught by our trainers, to medialize the patella button in order to lateralize the patella. And when we looked at that specifically with this device, top left, we've got a central sensor, so not medialized, right in the middle of the patella. If we medialize by about 5 millimeters, in order effectively to put the patella button over the apex of the native patella, we see a substantial drop in pressure in virtually all cases. So that really supports what we've been taught by our trainers, but we can see the device working in terms of actual recordings. At the bottom, you can see the difference between 1 millimeter resection. So 7 millimeter shim on the device to a 6 millimeter really replicates what's going to happen if you take 1 more millimeter off the back of the patella. The pressures start to drop. When we looked at more than 100 patients from multiple surgeons across the UK, some using mechanical alignment, some kinematic, some using robots, and others, we saw across the board an increase in pressure, particularly in the lateral side of the patella, between the native knee and the trial implants. This very, very complicated slide isn't quite as complicated as I thought when I was first shown it. It is those 100 patients across the board. The red are the lateral pressure sensors, the blue is superior. And we can see in almost all cases between native and the total knee replacement patients, substantial increases in pressure. So the aim of this device, the aim in the long term, is to help us to fine-tune the position and the depth of cut, the resection level, as well as the angle of cut of the patella in order to try and reduce this alarming dissatisfaction rate. So I'm going to hand over to James Bidwell. James has used the device over the last year or so in Aberdeen and is just going to go through a little bit of the technicalities of the device. Thank you, James.
Thanks very much, Nick. So I am just a fairly jobbing orthopedic surgeon from Aberdeen, and when this device was shown to me, I was a little bit dubious because I'm a selective patella resurfacer normally, like most of us, and I wasn't sure it was that much of an issue with regards to the tracking. But of course, the more you look into it, the more you realize this is a very underdeveloped area of research and practice in knee surgery, which is a strange thing, really. So the QuadSense device is very straightforward and easy. The important thing to recognize, it's entirely implant agnostic, so you can use it in any knee replacement system, a total knee replacement or patellofemoral joint replacement. It doesn't really matter whether it's robot or PSI or a standard knee replacement. It does take a little bit of time. I've probably I would say it added about 7 or 8 minutes to my surgical time whilst we all worked it out. But now I think it probably adds only 2 or 3 minutes maybe. Once the team get used to the equipment and the setup and the software, it's really very, very straightforward. The only significant change to your workflow is that you need to make your patella resection first. As soon as you've done your medial arthrotomy and your standard releases, you will get on and do your first cut. So the jigs within the set are very intuitive and straightforward. The key thing is this sensor, which is connected by a cable in your surgical field. You'll see the picture at the bottom. The sensor is clipped to the undersurface of the reduced patella here, and it's connected to a puck, which then controls all the images on the screen. The sensor itself has a variety of different clip-on patella trials, 6 millimeter, 7 millimeter, and I think it's 8 millimeter now. As you'll see, after your first resection, you have the choice of changing those pucks to simulate different angles of cuts. So once you've made your initial resection, well, actually before you do that, you measure the thickness of your native patella with calipers, and you can enter that into the software. You then make your initial cut. The jig you use is a fairly standard J&J type patella resection jig, which is very, very good and effective. You take off your thickness, generally it's 6 millimeters or 7 millimeters, and you do your first trial using the native knee surface to get your first graph of contact pressures by cycling the knee about 3 times. You can control the workflow easily from within the surgical field, and you can actually see everything in front of you, and your assistant and the scrub nurse can follow everything. You can now, with their new software, you can actually enter the implant type that you're doing, so that actually has within it the thicknesses of the patella component that you're going to use. I must admit, it's not something I really realized until looking into this in more detail, the huge variety in thicknesses of the patella components between different manufacturers, and some increase with the width of your patella button, and some are set, and the variability is really quite marked. Okay. So the monitor is quite small. It generally will fit into your operating theatre quite easily, and the design actually is very good. It's very clear, and everyone can see what's going on. So just to recap, you make a conservative resection at the start, having measured the thickness of a patella. And you can see here the jig at the top looks very similar to the jig I use in a tuned knee anyway. And then once you have actually completed your total knee replacement, you've got all your trials in position, you will do your full trial and get the contact pressure traces on the screen using, again, generally the same thickness button that you started off with. And you can then find out the whether, as Nick said, you've got this fairly typical finding of higher lateral pressure or higher superior pressure. There are then a number of buttons you can put on which will simulate you taking off an extra few degrees at the top or the bottom or the side on the lateral or the superior side, and you can increase the thickness of a button that you've used or reduce the thickness of a button that you've used, and you can then trial it again, and you can see the trace on the screen, and then you can work out the optimum pressure. So some of us will go for basically reproducing the original pressure from the original trace. I tend to try to reduce the contact pressure to just offload the patellofemoral joint in most circumstances. You can do the trial before you cut, then you clip on the jig, the corresponding jig, and just see on the bottom right there. So the corresponding cutting jig will allow you to take off either an increased thickness or an increased thickness with an angle. And then you can do your final trace at the end with your trial button in position, and then you can carry on and cement in your components. You can get a printout at the end, essentially. You can collect your data, and you can keep that in your records. I really have learned a lot from starting to use this. It has perhaps pushed me much more towards being a patella resurfacer in most circumstances now. And I think it is a very useful tool in your armamentarium. Thank you very much. We've got time for some questions.
So the questions to Mr. Bidwell. After using this, have you seen the dissatisfaction in your patients decrease in a clinical setting?
Thanks so much. Well, I have been using this for only 6 months. I have done about 10 cases. I think from a purely subjective analysis of that, I would say patients are happier. I don't think that's at all a proper scientific sample, but they're happier and I'm happier.
Yeah, and so I've been fortunate enough to be able to use it and help with a team of surgeons in the UK, New Zealand and America to direct it. We've we're collecting clinical data now. Now the device has been refined. What I've seen, and again, I'm afraid it's anecdotally, we don't seem to have those unhappy patients and with the total knees. I do use it, and it is off-label with the patellofemoral joint, and I haven't had any of those unhappy patellofemoral patients that we know does spoil surgeons' experience with patellofemoral arthroplasty, but it is anecdotal, I'm afraid. Oh.
Hi, Nick. Thank you very much for the presentation. You showed a very complicated-looking slide with the red lines and the blue lines all over the place. Out of the 100 TKRs, all of those obviously showed very high pressures. What proportion of those patients were actually dissatisfied with the TKR?
So that's intraoperative, so that's the first measure. So we do the initial conservative resection, we take a measure against the native knee, then we do the rest of the knee replacement, then we repeat it, and that's the first, before we fine-tune. So we aim to reduce the pressures back to the native, or I'm with James, in patients who have high lateral pressures routinely and have presented with lateral patellofemoral osteoarthritis, I'm trying to reduce the pressure compared to the native. So we don't leave them like that. That was an intraoperative measurement.
Sure, so, sure, thank you. So I just wonder if my question really regards, do we have the data for patients who have increased pressures and to see how many of those patients are actually dissatisfied?
No, because to do that you would have to have an indwelling pressure device, or you'd have to take the view that you just routinely measured and didn't try to reduce pressures.
So would it be correct to assume that you can have high pressures and for patients to still be happy?
Yes, and I think, only I think around 10% of patients are unhappy, and some will have high pressures. But about half of the unhappy patients complain of anterior knee pain. We've got time probably for 2 more questions. One more question.
Sorry, this would be a game changer for a patellofemoral replacement, where the problem is the patella a lot of times. It is deformed, it's got osteophytes on. How you resect the patella would make a big difference by this device. So just wanted to get your experience on the patellofemoral joint replacement, not the total knee replacement.
Yeah, so it's a little difficult for me to speak about that because it's off-label, but I think it will go on-label pretty soon. I think it's a game changer for patellofemoral replacement, and one of the things we've noticed, and we need to wrap this up, is removing the osteophyte just by itself about halves the pressure a lot of the time. So it's very interesting. It is work in progress, but it's very interesting, and I just commend you to take a look at it.
Yeah, I mean, how much osteophyte we remove would be defined by this device, which makes a big difference to the PFJ replacement.
Potentially, yes.
Thank you.
Thank you very much.